Anybody that has questions, please stand up, come to this microphone, ask the question from here so that we can all hear. Thank you very much.
Have you ever had any complications when you injected ozone in the tonsils?
No, not at all. What's important when you're doing the ozone infusions into the tonsils is that, first of all, you put maybe a cc, the most, really about a cc in each tonsil in a certain microgram range. There's a concentration, usually around between 10 to 15 micrograms. But what's important is you tell the patient, number one, within the next 24 hours or longer or shorter, expect a lot of weird, creepy things that come out of tonsils. Purple things, tonsil stones, a lot of drainage to come out of there. And you might have to repeat it within a week or so. Those come back a week later, if necessary to retreat them. Because when we're dealing with cavitational issues, chronic infections, you always must treat the tonsils because they're chronically always infected. Even though they may kind of look normal, don't be deceived. There's infection trapped in there for years in those tonsils, and a couple of ozone infusions will certainly clean those suckers out.
So what you're saying is if you have a cavitation, you also inject the tonsils?
Unequivocally. Anytime you deal with chronic infections of the jaws, whether it's from root canals, that you're doing extractions from, chronic periodontal issues that are bad, cavitation, always treat the tonsils. I mean, we have a whole lymphatic protocol, but for the cavitational thing, et cetera, it's a little bit more detailed than that. But at least treat those tonsils. I'm telling you, they're chronically infected. Even, my pal Tom Levy spoke about that today. And it's important you really do that. Because things, if you don't clean up the house, things are going to get reinfected. That's for sure.
Thank you.
Hi, Dr. Sims. How are you? It was really amazing to see the effect that your appliance had with patients. I was wondering, a lot of the children are diagnosed at a young age, and they're growing. And does your device, or is there a way to alter the jaw growth so that to take that pressure away so that they no longer need the device?
Yes. Yeah. Yes. Basically, for the children, it's all about growth. I mean, you got to think. Excuse me. One jaw is going to grow faster than another in certain cases. What you will never find, is you will never find a class 3 jaw with Tourette syndrome. Why? Because the jaw was allowed to grow. If the maxilla holds the jaw back, the epiphyseal growth is in the condylar area, which means it's going to grow backward. Growing backward means you're going to compress on the auriculotemporal nerve. The auriculotemporal nerve is the trigeminal, which causes the sensations of tics. So if you can control the growth, basically controlled arch development, you can get rid of those tics earlier.
Thank you again. This is the second time I listened to your lecture, and I found it just fascinating. I'm just curious because you're very, very cautious about showing us anything. I can understand that we want to do it the right way. Do you give any courses, or how can we learn how to do this, so God can help us too?
I have 3 left. I got 3 left, and you can have one of these. And they will tell you. They will tell you everything. Just give the girls a call. It's next year. It'll be May 17th and 18th of the year. Guess who's taking my course? Tell them how it was.
It was amazing. It's really an excellent course. You learn a lot about the brain and the reticular information and how to, we need to take a clinical course.
Yes.
But it was great to learn a lot about the mechanism of how it works.
Thank you for making this available. And I'm just curious, what happens down the road Children, I'm sure they will go into some type of guided orthodontics to allow the growth of the. What about the adults that, like that gentleman that was a little older, that black gentleman that you saw at the end? Will you encourage him to go into some type of orthodontic treatment as well, or some type of what is in the future for these people?
That depends, honestly. A lot of the older patients will say, "Oh, I feel better. Don't touch me, Dr. Sims. Don't touch me again, because I like it just like this." And they know that they will be in that orthotic and have to have it resurfaced every so often. I tell everyone that I don't want you to be tethered to me. So in order for you not to be tethered to me, you need either orthodontics or restorative. Orthodontics is going to cost you a whole lot less. And way to do that is with basically either a bionator or a twin block. And you can get that, basically a good orthodontist, a progressive orthodontist who knows what to do can help you get there and stay there. So now you won't need the orthotic or the orthodontics, and you're tick-free.
Great. I'm sorry, do your patients eat with your orthotic, or
No.
do they remove it to eat?
No, they don't eat with it. I tell them,
What
take
happens
it
when
out.
they remove it then? Do they start eating with their ticks, or?
That depends, because you're going to have the orthotic in what, 24 hours. Let's say 24 hours. You eat 1 hour, so you take away an hour a day. If you take away an hour a day, that's 20 minutes, or let's say an hour and a half. You're not going to lose anything in that hour and a half. After a while, the jaws change position, change proprioception, everything changes, and they stay in that position for a lot longer. So when they take it out, they can eat. Or, and let me make it perfectly clear. It'll be difficult to eat because they will always get, and I tell each patient, you're always going to get a posterior open bite, which then gets corrected with the orthodontics. But they still eat well. Trust me, they eat well.
Thank you very much.
Dr. Sims, on that line, and I'll ask the questions I had. If you're going to maintain someone like an older person with the orthotic, and they're happy with that, not going to go through ortho restorative, would a sleep appliance, if appropriate at night, maintain them during the night, holding the airway open and keeping them forward?
You can do that if you want to charge twice as much, yes. But the appliance that I have does the exact same thing.
Wear it at night?
Yeah, you can
Still
wear it at
hold it
night.
open.
So 24/7, except for eating, works just as well.
Okay. Then 2 questions, I'll ask them both and you can respond. You mentioned that there's 5 times more prevalent in boys.
Yes.
That's about the same ratio that we see in, say, autism or autism spectrum disorders, and we're seeing the same sort of, whether it's structural or neurological. Any correlation there, or is that just the same number?
The number, if I remember correctly, Tourette's and autism are about, Tourette's with autism is about 35%, or 35% of those who have autism have Tourette's. Let's say it that way, I'm sorry. 35% of those with autism have Tourette's, which tells me that there is a major connection. The major connection is actually within, number 1, it could be the gut, serotonin. Number 2, serotonin is, you said 80% of the serotonin is produced in the gut. Guess where the other 20% is? It's in the brainstem. Guess what nerve goes directly to the brainstem?
Gotcha.
Facial nerve. Who said that? Throw that man out.
The other one, do you see the same frequency of their Tourette's during their sleep, or when they go to sleep, do
No.
they have the same
No.
ones? Does it go away, or
It-
do
it-
they stay away? Does it keep them
No,
from resting?
no. The one thing that it does that you will not find too often, it does happen slightly, but most of the Tourette cases sleep pretty well. They even sleep better with the appliance. When they get their appliance, the first thing, I mean literally the first thing they say is, the parents tell me, he slept like a baby last night.
Okay.
I've never seen him sleep like that. And that happens to a lot of cases. And not just Tourette's, but all the other disorders that we talked about today also.
Okay. My question was, I should have said, do untreated Tourette's, do they still have their same frequency at nights, or does that?
No, they have a less
It
frequency,
drops
yes.
back? Okay, thanks.
No problem.
Yes, this is for Dr. Sims. I have a question about your therapies. If you've tried them on people without acute symptoms, people that maybe are suffering from mild cognitive impairment.
Yes, and it works very well. I've had probably about 10 cases of people who have come mainly from accidents, and they've had what they call mild cognitive impairment, and because they're, how can I say this? Let me think. Their ability to put thoughts together is not all there. I remember one kid who was knocked out from a football, game, and he had gone to every single neurologist, including the Pittsburgh Steelers neurologist, and could not get better. And when he came by, and someone in his church told him about what we do, told him to come by, he was able to count without failure and tell time without failure. That's one of the tests that we do, cognitive tests that we do. Able to write down with without skipping a beat, basically. And so it does work. It improves the connections.
Thank you.
And do you take MRI for every case?
Every case.
Okay.
Every case, because you don't want them to come back and say there was nothing wrong. And as a matter of fact, when you do take the MRI, you'll actually see the problems that are possible, the possibility of what's being wrong in the TM joint cases. Everybody gets one in my office. Everybody.
And this morning you talked about the Parkinsonian patient and said something about an MRI looks normal in a specific patient. Which one was it?
In Parkinson's disease, you will see neurodegenerative changes in the neuromyelin of the substantia nigra. That I can't change. But in Parkinsonism, the MRIs look normal. The symptoms are there, but the MRIs are normal. What you'll find is they will have all the symptoms such as slow gait, the dystonia, the bradykinesia. They can't do a lot of the same things, or they do a lot of the same things that Parkinson patients do, but they can't find it. So what they tell them is, well, you just got to go through PT, or you got to stop this drug, or whatever, because in Parkinsonism, drugs don't work very well. So if they don't work very well, guess who can possibly help them? Everybody wants me.
Good. Thank you.
I'll call her later. You know, the wife. The boss. Yeah, sorry, the boss. I call the boss later.
So this question is for Mary Lynn. I loved your information on the vitamin D, especially the study about the toxicity. And I'm just wondering, after your periodontal therapy, and you're assessing their vitamin D3 levels, and I'm assuming it's D3, do you reassess at a certain point after your periotherapy? Is it, maybe it's individual, 3 months, 6 months, annual? I'm just curious if you had a baseline too of where you'd like them optimally during the active therapy, and then maintenance-wise, do you retest?
Well, from the research that I came across, they were saying that your vitamin D level, one study I saw was if you've had cancer, to get your vitamin D level at 100. And if you don't have cancer, get your vitamin D level at 100. And having your vitamin D level at 100 was as effective as if the patient, I believe it was in chemotherapy and had surgery, that the morbidity rate went down. And so they were parallel. And then in the tamoxifen study, where it said that vitamin D was as effective as the drug tamoxifen, it also maintained that vitamin D didn't have the side effects. So typically when we're doing the the periodontal therapy, many of our patients haven't ever taken vitamin D at all. And it vacillates a little bit. I usually have them check with their naturopath, their chiropractor, their PCP as to, especially if they're in some kind of active treatment, you don't want to rock the boat. I'll just tell the patients, we're all typically deficient, and to get your level tested. And then we usually recommend 5,000 IUs of the vitamin D. Now that said, there was one patient that I've had that couldn't methylate vitamin D3. I thought at first, this is not adding up, and then took a course in methylation and realized she was a classic example. 2 different times she tried to take the vitamin D, and her hand swelled up the first time. So she thought, well, the only thing I've changed is really the vitamin D. So she stopped, and when she told her primary care is like, that's a bunch of crap. So I want you to go back on it. And she did, and the second time she couldn't even dress herself. Her husband had to dress herself. So I will leave it up to the patients, but I just tell them I'm a fan. I tell them my vitamin D vacillates between 84 and 109, and I don't make any excuses for it.
Well, thank you very much for that.
So this would be for Dr. Sims and the anatomist. Brush up on the course and position of the auriculotemporal nerve. Is it, I need a reminder, is it part of the capsule? Is it separate from it? And then does that have any risk factor or any correlation with maybe a posteriorly, displaced mandible impinging on that?
You're a smart guy. That's absolutely true. The auriculotemporal nerve goes under, around the condylar head, in between the condylar head, posterior wall of the glenoid fossa, which is the anterior wall of the external auditory or internal auditory meatus. When you have a posteriorly displaced mandible, you will actually see in a lot of cases a anteriorly displaced disc. So you will see less space, and you asked whether you get a MRI. I get an MRI on every case, because if you only have CT scans or any other X-ray scans, you're only getting half the picture. In order to get a complete picture, you need to have, you have to have an MRI. And what you'll see, you won't see the nerve, but what you will see is the amount of space between the condylar head and the the anterior wall of the glenoid fossa. If it has a very small amount, or it is up against that wall, you know almost for sure that that nerve is being pinched, and you can test that out with certain tests that we do.
So would that dictate your course of treatment? I mean,
Absolutely.
beforehand,
Yeah.
before you initiate any treatment?
Yep. Everybody gets an MRI in my office, and I read every single MRI. I teach you how to read MRIs, because if you don't know, if you can't see it, you can't treat it. If you don't understand it, you can't treat it. So you have to see it, understand it, and then treat it.
Hey, hi, Greg Bregel, Anchorage, Alaska. You're all invited. I know everybody wants to vacation in Alaska, so come see me. So, I retired from biological dentistry about a year ago, and I'm currently working a public health clinic. So, we're contemplating getting a cone beam CT, 3D CT. So, the question is run back and forth numerous times. So, kind of a general question to the group. Where does our liability lie in reading that? So if we take that, are you responsible for everything on that cone beam? So if you miss something, is that a problem?
That's why you send anything you're not sure to a radiologist. You're responsible for everything in the volume.
Even if you're not sure.
Even if you're not sure.
Beam readers, we send everything to beam readers, and that takes it off my back.
That's going to be a problem for a public health clinic, though. You know. So limit the field of view is just what we really want to see. Like example is that are just the teeth, are they infected? You can do that on CT cone beams, yeah? Yeah, okay. Good suggestion, thank you.
I have a general question for all of you, intelligent minds. Bruxism. When I went to school, it was caused by stress, and I used to make 2 dental guards, night guards a year. Now I make 2 a week for my patients. Any comments, any ideas? Dr. Sims alluded a little bit to the bruxism today. Phil, I'm sure you have many opinions on that, and you alluded to a nice, beautiful, we made bite appliance as well, passive appliance, and I'm just wondering what your opinions are here. You're experts here. Let us know.
Airway is really big. Usually if you get rid of the lateral interferences, bruxism will go away. Like on the guards that I make, they don't brux them, or there's no marks in them. I can't destroy them. So that typically goes away. Clenching is the one thing that I can't always get rid of that one, but the bruxing almost always. When they're balanced and stable, I think it's a subconscious mechanism to get rid of the interference.
Say again?
I think it's a subconscious mechanism to get rid of the interference. When the grinding, the clenching, that a lot of times will hang around. But the bruxing almost always goes away when they're stable.
Now, noting the sounds, if you go back, mammals love...
Get the mic. Get the mic, please.
Oh, the mic? If you go back historically, that if you look at mammals as a general species, what I call it, mammals love to sharpen their teeth. It's an old inherent mechanism. Now, whether it transfers into humans or not, but they love they grind and brux their teeth. It's a sharpening mechanism. It's an old, I don't know if you want to call it a parafunctional hack, but mammals in the world love to just grind and sharpen their teeth, especially in the New York metropolitan area. They're always sharpening their teeth. I'm telling you, it's unbelievable. Am I right?
Absolutely.
So you get fit over there, so it's a big problem.
Dr. Sims, any opinions?
Yeah, I told you at the American Academy of Neurology, they did a I forgot the gentleman's name, but he did a trial on bruxism and restless leg syndrome, and over I think it was 70% of those who had restless leg syndrome had bruxism. But when they did the CPAP, it changed to 80% corrected. That's why I remember it was 77 and 80.
My functional therapy with it, you're going to get even better.
Probably so.
No, that's all I have.
Just to follow up to clarify on his question, I thought it was an excellent question. A lab that I send my bike guards to told me that their percentage of business for making a bike guard 10, 15 years ago was like 10% of their business. Now it's 80% of their business. And I just see that so much in my practice too. And I'm wondering, is there some environmental thing? That's kind of what I'm wondering, or is this just, I've got a crappy population of patients who have imbalances in their bite? I don't know.
Definitely the crappy patients, I'm sure. Cell phones.
Has your population gotten older?
There's a prevalence of children too that, like you'll have entire families where parents describe going and checking on the kids at night as something they don't want to do because it sounds like the inner sanctum. This noise is coming out of the rooms. And it's like I never heard this when I was younger and practicing. I don't know, maybe I'm more in tune to it now and I'm just aware of it, but I see it on almost every patient I see.
Sleep disordered breathing, especially with the kids. If there is any kind of myofunctional habit, thumb sucking, pacifier, etc., it's actually limiting the airway. You're minimizing the growth of the plates of the maxilla and the mandible. A lot of these kids have obstructed airway, and that's what's causing some of the bruxing. So, and then I think we're recognizing it more. So, and plus the lifestyles that we have now are definitely different than they was 10, 20 years ago, but especially with the kids. If I see a kid as soon as I see it on the medical history that the parent's concerned about bruxing, I'm looking at the airway. And then I'm gonna make sure that that kid gets a sleep study. I make sure that the patient goes to the pediatrician and gets a prescription for a sleep study. So that's part and parcel of.
What about being tongue-tied? Would that reduce it? Is it just kind of constantly kind of loosen that tongue up?
The mic you have in your hand.
Oh, what about the concept of tongue-tie?
Well, the tongue tie, the tongue can't go to the roof of the mouth. So, that it can cause actually some airway issues. It's very easy to do in your office. You just numb it up and snip it out. You can't believe the difference. I just gave a course, I showed a video how that tongue just goes right up to the palate. So it makes a huge, huge difference. And then with myofunctional therapy and then corrective medical dental intervention, now these kids are breathing better and the bruxing's going to reduce, and a lot of these habits are going to be improved greatly. So, but I think we're like I said before, I think we're recognizing it more than anything else.
I think you're recognizing it more, plus you also have second-generation junk food kids. So the nutrition has played a horrible role. Horrible nutrition has played an important role. You have second-generation margarine kids, and they don't have enough fat for full maturation.
Unfortunately, I think some of it's profit motive. They're quick, they're easy. They shouldn't be, but a lot of times they are. So, with people, you can charge a ton for them. People pay for it, and I think with the insurance and the mills that we're running, that's another, quick $500-800 a pop. And if you can have your assistant take the impression and put it in, I think that happens a lot. I don't think it helps anybody, but
Right, but I'm looking at a series of symptoms that I'm seeing on people,
Yeah.
and, you know, those worn teeth and
Yeah, but I'm thinking those.
all
I
of
mean,
those
that
different
number
things.
going up to 80%. I think. I mean, it's just. I mean, they're marketed like crazy, in all the big magazines, and
Yeah.
I think there might be something there too. I don't agree with it, but.
I have a question for the whole group and maybe other people here too. I'm wondering if there's any research about mercury released from mercury fillings during any kind of cleaning procedure, not with polishing, not with the ultrasonic, but mostly from hand instrumentation. In my practice, we try not to touch the mercury fillings with the ultrasonics, but we still have to do the hand instrumentation. So I'm wondering, should we be having respirators on the hygienists? Or do you know of anything?
I think any abrasion against restoration
Yeah, that's okay.
All right.
It's in your hand. No, it was across the room.
Wait a minute, oh, where were we?
Maybe it's by the mirror.
Oh, there, mirror. Anyhow, I think any kind of, scraping, abrasion against any kind of mercury film is going to release some level of mercury.
I know, that's
Yeah.
what
I mean, you realize now patients, especially with, taking, pre-medications for the procedures, I mean, physicians are backing off on that, because we're finding that patients do more damage to themselves than we do, and in a few hours we see them a year. So, they're taking their abrasive toothpaste and scrubbing those beautiful mercury things, and, chewing on bones and everything else known to man, and, what minimal things we truly do, so we're very cautious about avoiding the mercury fillings, et cetera. But any kind of abrasion is going to, it's 50-something% mercury, you can release from mercury. How much effect it has on the patient? Well, that's just accumulation.
Even if you don't touch it, it's still the patient's
Yeah.
breathing on your hygiene.
Absolutely.
You should be
Yeah,
working
I'm
with
one.
it anyway.
Yeah, I'm thinking about the hygienist, but it's the patient too. That's true. Okay, thanks.
Just wanted to comment on the Bruxism, and I think there's multiple causes, but definitely sleep disordered breathing. There is, if you've watched, I watched numerous videos videoing somebody that has sleep disordered breathing, and there's a concomitant post-apneic clenching and bruxing that is severe, and it happens right after an apneic event. And I don't care, no matter what you do, if you don't take care of the apnea, you're not going to get rid of the bruxism, because that is how the body opens up the airway, gets those muscles to reactivate, loosen up and open up, is that reflexive thing. So I believe there's multiple reasons, including posterior interferences and tooth interferences, that cause and stimulate the avoidance pattern in bruxism. But I mean, I've watched too many videos of sleep disordered breathing, and it's almost painful to watch when they go through that post, well, first of all, to watch them have the apneic event in the first place, but then have that clenching and see the muscles flex and hear the noise sometimes from that so definitely sleep disordered breathing needs to be addressed.
I would offer just a couple of things, and for opinion there, as you were talking about the children and different things in the diagnosis that we've seen. One of them is consider Wi-Fi, especially when it's on all night, and also the smart meters, in the location of electric smart meters and the amount that is put out. I mean, even to the point of a type 3 diabetes, due to that. So don't forget that in the differential diagnosis. Ask them if they're sleeping by a bank of smart meters, maybe on an apartment or something. Exactly.
It's just a quick suggestion for the lady who spoke about mercury and hygiene and fillings and so on. What we did at one point, every patient that came in hygiene had to rinse with activated charcoal slurry and swallow that before. And the patient says, oh, why do I do that? Well, that gave us an opportunity to tell them about the mercury fillings that we probably recommended before that they be removed, but they didn't go into that. And when they find...
I'm stealing that, by the way.
Say again?
I'm stealing that. I'm in charge of training in my
Yeah.
practice. I'm stealing that idea. You hear that, Dr. V? Okay? You're on it on Monday morning.
It costs
Okay.
peanuts. It costs peanuts, and it protects your hygienist, too. Yeah.
And it gets the talking about it.
Trying to get rid of our charcoal.
The patient, yeah.
All right, I'm back. Trouble. So the sleep apnea, all those people that teach the courses in last 10, 15 years is just exploding. And a lot of us have made a lot of these appliances. Glidewell makes a lot of them, Elite and Tap, and open the airway, bring the mandible forward. So should those people be wearing an appliance during the day as well? I just thinking about all the things we learned today about airway and all these dysfunctional problems.
I do know Dr. Gelb has appliances for day and night. He does a lot of airway, Michael Gelb. And there's other appliances. I'm sure you could wear them. Every patient has a significant problem. I'm going to tell you what I do. I have an airway issue. I have malatitis score of 4, which means my tongue, you can't see the back of my throat. I mouth tape at night. My husband's like, oh God, I didn't want to do that for years, but I mouth tape, and it forces me to breathe through my nose. And it really makes a huge difference. You take 3M micropore paper tape, and you just put it across. And you know, it looks barbaric, it looks horrible, but it really, it doesn't bother me. In fact, I wake up in the morning and I feel fabulous. And if there's some nights that I don't do it, you can ask my husband, stay away from me, because I am miserable. Something. I know some people I might want to do it to. But yeah, that's my 2 cents.
Bill, we got crazy glue here.
Yeah, well, yeah, crazy.
Works wonders. Bill, thanks for coming.
Sorry. It's for Dr. Babcock. I was wondering, have you had any experience or success in treating patients with an open posterior bite, and how the TMJ is affected by having the initial contact on the anterior rather than on the posterior, and not being able to like translate into normal closure?
I don't think I've treated any open posterior bites, but I finished up a case just a couple weeks ago, actually. I was going to restore her, but when we ended up, she had a posterior open bite, and I sent her to ortho. I didn't want to pile up a bunch of composite on the posterior teeth. It's just, I mean, it's the opposite of what it should be. I mean, a lot of times on the second molars, I'm adding just a little bead of composite in a few areas. I don't really like to cover occlusal surfaces if I don't have to.
Cool. And do you put the patients in a night guard after your therapy?
Yes.
Okay.
Yeah, I do. I was treated myself 13 years ago, and I've never worn a night guard. I've never had a chip or a fracture. I mean, my occlusal marks are the same now as they were then. It's just safer for any clenching that doesn't go away.
Okay. And the patient that you described, the case, did she have ortho previously?
She did, and she was debanded a year and a half before I saw her, which means her symptoms started right after her ortho came off. And that happens a lot because when you're in active orthotherapy, things are moving around, that deprograms the muscles. And so if you have somebody in TMJ pain, they go to ortho, they're going to feel better during ortho, but as soon as it comes off, it's going to come right back because they're still not working with the stable joint.
Okay. And was she wearing her retainers the whole time, or did she stop wearing them?
I don't know.
Okay.
But it doesn't really matter at that point because things are stabilizing and those, yeah,
okay.
It'll come back.
And I have a question for Dr. Sims. So does the mouthpiece that you put in, does it bring their mandible forward?
In some cases, yes.
Okay, and does it, over time, does it help realign their condyle to where the pressure will eventually be let off?
Yes.
And they won't have to wear a mouthpiece anymore?
No. It develops a posterior open bite, which is what we want to happen. And then we do orthodontics to close up the space. And that, you can do twin blocks, which will close up the space. And therefore, they won't need a orthotic or orthodontics afterward, and they're tick-free.
Thank you.